Good morning, everyone. Welcome to day 2 of the International Conference on Integrated Care, and thank you for joining us for session K, Co-Designing Care, and I don't think you could have picked a more beautiful room to join us in. We're excited to have both in-person and virtual delegates joining us today. My name is Sarah Precious. I'm the Manager of Engagement and Communications for the Greater Hamilton Health Network, and this is Michelle Nelson, and she's a scientist at Sinai Health, and we'll be your co-chairs today. Before we begin introductions, I'd like to just take a moment to speak about a couple of housekeeping items. Each speaker will have 15 minutes to present, and you can submit your questions via the conference app, or you can raise your hand in person and we'll come around. Time will be available at the end for questions, just to make sure that our speakers have their due time to speak and share their information. And if there is a question that's asked that's better suited for a one-on-one, we'll make sure that you have that time afterwards to speak to the individual speakers. Okay, without further ado, I would like to welcome Megann Dong from Western University to come and speak with us. Welcome, Megann.
Perfect. Hi everyone, I'm Megann Dong, and I'm from Western University in London, Ontario, Canada, and I'm really excited to be here today to talk to you about examining individualized participatory approaches to care for individuals with intellectual and developmental disabilities. So to start off, I'd like to acknowledge the time, resources, and funding of my university, PHSS, and the Canadian Institutes of Health Research, as well as my team, many of whom are here today with us. So to start off, our research was conducted in a city in southwestern Ontario, which is located, it's called London, and it's located where the little plane is at the bottom of Ontario, and has a population of approximately 543,000. London is located within the province of Ontario, which is where the arrow is pointing, and has a population of approximately 14.5 million, and then Canada has a population of approximately 38.25 million. So we worked with a provincial community care organization using an integrated knowledge translation approach to answer the research question that's highlighted above. And to give you a bit of context on the community care sector in Ontario, it offers a range of health and social care services to address daily living skills, such as help to get up in the morning and preparing meals, complex medical care, such as chemotherapy, personal care needs, such as help using the washroom or taking medication, as well as social care, so help accessing education, meaningful activities such as paid or unpaid employment, or lifetime goals, such as finding a loving partner. So PHSS is the provincial community care organization involved as collaborators on this project, and they are based out of London, Ontario, Canada. They offer a range of services for individuals with a wide range of needs, with many of them having very complex needs. So individuals who are ventilator dependent or medically fragile. And PHSS offers person-centered services that effectively recognize each individual's unique needs. So we wanted to look at PHSS's individualized participatory approach to care, which is facilitated through person-centered plans. So the person-centered plans at PHSS are annual goal-setting meetings, or they call them celebrations, to talk about the person's likes, goals, talents, dreams, and aspirations. And the person typically involves their community, so they invite any loved ones, anybody who plays a meaningful role in their lives. So this typically is friends and family, it could be a loving partner, and then there's also day-to-day support staff and a facilitator that attends the meetings. So we conducted a scoping review looking at the types, features, and supports of individualized participatory approaches to care within the literature. We looked at 6 databases, which are highlighted in the right top-hand corner of the screen. And so the inclusion criteria were for articles published in the English or French language that looked at participatory or co-designed approaches to care planning at the individual level rather than the program level. It was for individuals 18 years or older in terms of age rather than legal status. It was for individuals with intellectual and developmental disabilities or medically complex care needs within the community care sector. So we found 675 articles at the beginning from the 6 databases, which turned into 505 unique results. And at the end, we had 26 articles that were included in the scoping review. We also conducted semi-structured qualitative interviews with 11 PHSS staff to look at the impacts and supports of PHSS's approach through a pragmatist lens. So in terms of the scoping review results, there were 6 articles from the US, 6 from England, 4 from Australia, 3 from the Netherlands, and 2 from New Zealand. There was also 1 each from Ireland, Denmark, and Canada. 11 out of the 26 articles were qualitative methods, 5 were opinion pieces, and another 5, which makes up about 19%, were review articles. And so what we found were that there are a diverse approach and focuses for care planning. This included financial, so budgeting money, education, employment, and then goals or dreams that the person had. There was no consensus on the purpose or procedures for care planning methods. As well, there were limited evaluation on the impacts. In terms of the results of the qualitative interviews, the impacts on the person supported were because the person-centered plans are person-directed. The person gets to create what they define as a meaningful life. So in this example, this person's goal was that they wanted to teach, and this led them to teaching at Girl Guides. And then their goal evolved. So then they taught at a local college and eventually the university. This is also an example of community participation or integration. PHSS really values community participation, whether this be through taking classes in the community, joining a local choir or sailing club or sports team. And this integrates the person into the community where they may not have had an opportunity to without the supports. So this is an example of a person who had a daily living skills goal. This individual was previously placing their meal on their lap to eat within a secure unit, and their goal was to eat at the kitchen table 3 times a day for all their meals, and so they started off with 1 meal a day at the kitchen table. The impacts that we've seen from the person-centered plans are not only on the person supported, but also their family and the staff who support them. The person-centered plans provide direction and motivation over the next year or so, depending on the size of the goal. It provides goals and direction for staff to best support the individual based on their definition of a meaningful life. And it also provides a common goal for staff to work together effectively. So the supports of the person-centered plans start with the staff. The organizational culture at PHSS is a big foundation for their person-centered approaches, which is facilitated through the person-centered plans. And the staff really are at the center of providing the person-centered services. So staff who are enthusiastic are able to motivate the person and have a positive outlook on life, are huge supporters of the process. The organizational culture at PHSS also have a huge leadership support. So it was a common theme to hear that staff felt very well supported by their leaders, and it really shows that the person-centered model is embraced at all levels from top to bottom. So this quote is about the flexibility and the adaptability of the models that PHSS has. When we're talking about person-centered services, flexibility is key. People can change their minds on their goals or want to try new things, so flexibility and adaptability are really important. It's important that there is a common understanding of this so that people from stakeholders to frontline staff understand this and are able to facilitate the person-centered services to the best of their ability. And the highlight of this quote is that PHSS's vision is that each person is unique and they have unique needs. So our study aims to inform PHSS in the spread of their approach to care and encourage care professionals of similar vulnerable populations to implement similar approaches. With interviews, there's also social desirability bias, where interviewees give answers that they feel are socially desirable or that the interviewee is looking for. 2 out of 11 of our participants identified as male, while 9 of them identified as female. And we interviewed staff, while future research should look at the perspectives of persons supported as well as the process in other organizations. And so I'd like to end you off with this. I'd like to have you think about how you would define a meaningful life for yourself. What achievements would you have to make to consider yourself to have lived a meaningful life? What steps would you take to achieve these goals? What resources would you draw upon to help you in the support of achieving these goals? Think about how your goals and your definition of a meaningful life can change, develop, and evolve over time. Now think about this flexibility and consider how we can implement this for communities we serve, because it really is amazing how a person-centered, goal-oriented approach to care can facilitate the meaningful lives that are defined by the person. And so this quote is one that really resonated with me. I think it really shows the organizational culture at PHSS in terms of how they really focus their services on supporting the success of the goals. Thank you.
That was wonderful, Megan. Thank you so much for guiding us through your presentation and also inspiring us to reflect and consider some of those questions about our own experiences and hopes for the future. I would like to welcome Eva Dumon from the Flemish Centre of Expertise in Suicide Prevention from Ghent University. Welcome.
Good morning, good afternoon, everyone. I'm Eva Dumon, and I work as a researcher at the Flemish Centre for Suicide Prevention in Flanders here in Ghent. And at the core of our work is actually trying to find the best approaches to prevent suicide in Flanders, and we do that by translating research into practice and by working together with a variety of stakeholders. And that's the focus of my presentation today. So a little bit about our center. We are linked to Ghent University. This means that we conduct research on what works in suicide prevention. And this research guides us to inform policy. We work together with the Flemish government. We are also supported by the Flemish government. And we coordinate the Flemish Action Plan for Suicide Prevention. And the research also guides us to develop information and tools for people who have suicidal thoughts, for people around them, for health professionals, for journalists, etc., many stakeholders. And all this information and tools we provide through our platform, which is zelfmoord1813.be, which we run together with the Suicide Helpline in Flanders. A little bit of background. I wasn't prepared that I wasn't going to see my slides, so I will have to look at the screen a couple of times. In Belgium and Flanders, unfortunately, we have quite high suicide rates, higher than the European average, so this makes suicide a very important topic. And from 2000, the government has started initiatives to put this on the agenda and to invest in suicide prevention. And then from 2006, we had a first regional action plan on suicide prevention, followed by a second action plan, and currently we are working on the third action plan. And fortunately, I can say that all these investments and all these efforts, not only done by the government, but also by health professionals, by many, many stakeholders, had a good effect to the extent that we have seen in the past 20 years a decrease in suicide rates with 29%, which is quite a hopeful number. Of course, since our suicide rates are very high, there's still a lot of work to do, but we see a positive evolution. And we also saw during the pandemic and the COVID crisis that actually the rates didn't increase, something we all expected, but that didn't happen. So we think on a policy level, we are doing quite well. So now we are working on the third action plan. And there again, we always work with health targets. And this health target now is that we want to further decrease suicide rates by 10%, with 10% by the year of 2030. Yes? Oh, that is so helpful. Thank you. I couldn't see it. Oh, much better. Okay. So how do you build an action plan? Today we're talking about suicide prevention, but you can also link it to other topics or other subjects. Well, for suicide prevention, our action plans always consist out of a couple of different strategies. These are the strategies that are in our third action plan now. There's strategies about promoting mental health to the general population. There's a strategy which focuses on training gatekeepers in suicide prevention. A strategy which focuses on developing interventions for vulnerable groups who are at risk for suicide. We also have a lot of interventions and actions focusing on improving care for suicidal individuals. Supporting people who are bereaved by suicide is also an important strategy. And of course, also with the topic of today, conducting research is so important in this action plan, as well as monitoring and evaluation the different strategies and interventions of the action plan. So how do you build an action plan? How do you build an intervention? We always opt for a stepwise approach. We always start with needs assessment. What does a specific target group or a specific setting need? What are their needs in terms of suicide prevention? Then a second very important step to us, we always look in the literature, we always do a literature review to know for sure what works best, what has been proven to be effective strategies, effective actions. As a third step, we try to translate these needs and this evidence into an intervention or an action. After that, monitoring obviously is very important. We want to know if this intervention is working. Does it decrease suicidal ideation, for example? Does it support people who are bereaved? And we also focus on that during an evaluation. So the key elements in this process is research. Actually, in every step of this process, we try to include a research perspective and participation. In every step of this process, we try to work together with as many stakeholders as possible. What are then specific criteria for an intervention? What do interventions need to have? Well, they need to be tailored to the needs of the target population. They need to be evidence-based. They need to be cost-effective and sustainable. If possible, we like interventions to be innovative, and they need to have an evaluation strategy. And actually, during the development of this third action plan, we had a lot of working groups with a lot of different stakeholders, and every stakeholder could do proposals for actions, proposals for interventions, and then we would gather all these proposals and look at this criteria, and based on these criteria, we would select interventions and integrate them into the action plan. Now, to make all of this a little bit more concrete, I'd like to give you two examples of interventions that we have been developing in our center. The first intervention focuses on guidelines that we have been developing for health professionals, and a second intervention focuses on the development of online tools for suicidal individuals. So in 2017, we launched clinical guidelines on suicide prevention. These are guidelines for health professionals, but really multidisciplinary, so not only for psychiatrists or GPs, but also for nurses, psychologists, social workers, on how to detect and treat suicidal ideation and suicidal behavior in patients. So we wrote this big book, but obviously people don't like to read big and large books, so we translated the recommendations in our book to an e-learning course, which has been implemented all across Flanders now, and which has been a bit more successful than the book, I can say. We had, from 2017 up till now, more than 20,000 unique users following this e-learning course, which then provides a sort of standard of care and a sort of common values and interventions that health professionals in Flanders share. So how did we develop these guidelines? It was a long process, I can say. Also here, we started with a needs assessment. What do clinicians need? What do health professionals need? And back then in 2000, I think 16, 15, there was a very high need of health professionals to have specific tools and specific guidelines on how to, for example, recognize signs of suicidal ideation, how to talk to patients about suicidal ideation. So then we did a big review of all the scientific literature on the detection and treatment of suicidality, and we also scoped through good practices from all across the world, just to look at which interventions have been proven to be effective. And then we translated these needs and this evidence into practical recommendations, really focusing on what are the core, what is the core knowledge, what are the essential skills that a health professional should have in order to improve care for suicidal individuals. We gathered feedback from a lot of stakeholders, not only from clinicians themselves, but also from patient organizations and from other stakeholders, to make sure that the recommendations were practical enough and they could be implemented. The implementation actually is still ongoing, and we're still monitoring the results of these guidelines. So we conducted, for example, an evaluation study on the e-learning, which showed positive results. We also worked together with health inspection to ensure that the guidelines are actually put into practice. And right now we're actually evaluated the guidelines, and we are working on an update. The updates will be launched by the end of this year, because there were still a lot of new needs that popped up over the past years. And so we'll be providing these updates. And central in these updates is also that we're going for a more person-centered approach. So I'm happy to hear about all these good examples here at the conference, because we used to be, in suicide prevention, very focused on the risk. What is the risk of this patient, and what is the risk of this patient? And it was all about risk, and it is still a lot about risk. But we actually want to have a shift in that and focus more on what does this person need and what does this person need. And focusing on risk is not always useful, not for the patient, but not for the health professional as well. So we want to try to make that shift and give patients more autonomy than we did back then. A couple of strengths and challenges. I think the strengths of these guidelines are the scientific approach, the fact that they are evidence-based, which is very important in suicide prevention because it's such a sensitive topic. We need to make sure that what we are doing has proven to be a good practice. The multidisciplinary approach, as I said, it's not only a job for psychiatrists. Suicide prevention is everyone's job, and everyone can contribute to that. The accessibility, everything we develop is actually freely accessible on our website. I think these are the strengths, but then some challenges as well. Suicide prevention is very, very complex, so actually guidelines are not enough. We need more than guidelines. That's why we also try to stimulate existing health networks to put this topic on the agenda so that different care providers can interact with each other on how they approach this and exchange ideas and experiences with each other. Another challenge, one size does not fit all. Our guidelines are very general, but we have seen that some specific target groups have different needs, or with some target groups there's a different approach. So currently we're also working on more specific guidelines for young people and more specific guidelines for people with autism. Then a second example are the development of some online tools for suicidal individuals. Over the past years, we developed an app called Backup. It is an app in which people can find a safety plan, in which people can find tips and help whenever they're in a crisis. So it helps them to overcome a crisis, and it helps them to deal with their suicidal thoughts. The app is available freely in Belgium and also in the Netherlands, for the people here from Flanders in the Netherlands. Another tool we developed is an online self-help course called Think Live. It is a course that it's also freely available, so actually everyone can follow this course. It's based on psychotherapeutic approaches, and it's a bit like the app. It helps people to overcome a crisis. It helps people it gains them insight into their suicidal thoughts, and it helps them to deal with these thoughts and behaviors. So also here, the development process is quite similar as before. We started with a review of scientific literature and good practices to know which elements should we include in this app and in this course. So we translated this into practice. Again, here a very important element. We gathered feedback from suicidal individuals through research. For the app, we did an evaluation study, and for the self-help course, we did a randomized controlled trial. Both studies showing actually very positive results, as well as in terms of feasibility, usability, as in terms of it actually helped people in dealing with their suicidal thoughts. It actually decreased the suicidal thoughts that they had. Also here, implementation is still ongoing. We're trying to implement it for a variety of target groups, a variety of settings. We keep on monitoring the effects. And also here, we constantly work on updates, often technical updates as well. For example, in the app, there's now a direct link to WhatsApp. So people can, if they want to contact someone, they can directly do that through WhatsApp. So a couple of strengths and challenges of these tools. Also here, strength, I think the scientific approach, again, makes these tools strong and effective. They can be used by individuals, as I said, but also by clinicians. So we also encourage individuals to talk about these tools and work with these tools with their clinicians. And we advise clinicians to advise these tools to their clients or patients. Also here, accessibility is an important factor and strength. Challenges, yeah, we see some groups are very hard to reach, and we see mainly that our tools are used by women and much less by men, so that is like a working point for us. Also, I think we can make our tools more inclusive than they are now, so that is something we want to work on in the future. And another challenge, I think it will be recognizable for a lot of you. These updates often require technical updates, and these are very expensive. So that is always something that you have to take into account when using digital tools or digital media. So conclusion, suicide prevention, a very complex topic, so it requires a multi-level and stepwise approach. In order to be effective, interventions and actions need to be evidence-based, participatory and inclusive, easily accessible, cost-effective, sustainable, monitored, evaluated, and updated regularly. And in this work, collaboration between researchers, people with lived experience, stakeholders, policymakers is key. Thank you.
Thank you. That was very informative, and I really appreciate your practical approach with so many, examples of how this could be applied locally, I think, or across the world. I would like to welcome Annefrans Van Ede from Health Campus The Hague. Welcome.
Thank you so much for introducing me. And I want to start with telling to you that this is probably not your average scientific presentation. So I would therefore also like to invite you to look up and see what kind of hole we are now. So you see above, for the people watching online, I'm not sure if you see it, but there's a skeleton of a giant baleen whale. And for the people that came from behind into this hole, there's a beautiful butterfly garden. So you can see, and this presentation starts with a view of perspective. So if you start looking at the butterflies, you're the onlooker. And the butterfly might be captured because in the exotic garden, but you as an onlooker are not captured there. So you have a different perspective. And therefore I would like to say, this is my perspective on my story. I will tell you something about my story, and that's a story of 2.5 years packed in 10 minutes. I skipped a lot of parts of the whole story because, yeah, in 10 minutes you can only tell so much. So I was an embedded researcher in a management team, and that meant that I was in practice, but with still a research-orientated mind. So that was a really interesting learning journey for me. So I will tell you something about that. And the embedded team, the team I was embedded in, was a team with a third-party perspective in a regional health initiative. And I will tell you also something about some examples that we did on community engagement in this regional initiative. So the team wanted to support regions to start looking towards health and not necessarily care. So in the gray area you see siloed care, health services, different services, and we wanted to support the region to start thinking about health and also do that with the support of organizing differently, financing differently, and also monitoring differently. So with the principles of population health, aiming for the quadruple aim, you might have heard also already on this conference previously. So this is the health geek team I was in. So I'm the little cartoon in there. I was in the team of Health Geek, and the team of Health Geek supported the region. So this specific example was Region A, which is a region in the Netherlands with approximately 400,000 community members. They set up their board of directors, and in the board of directors there were members from the hospital, from the municipality, from the mental health, but also the home care and the nursing homes. So there were a lot of board members, and I say that because that was their perspective. So it's the perspective of the board members that we were supporting from out the Health Geek team. And then me, myself, as this is my journey, I was supported with my scientific team to make sure that we could support as best also the Health Geek team with the scientific knowledge that we could bring. And important to mention here is that Health Geek got into the region with the idea that the regions should take accountability for the quadruple aim. So the region, it's their region, and they as organizations should strive for their community members. So Health Geek was there to support and not necessarily take over that accountability. So as we did action research, we also had like a dual objective. So we wanted to change practice and support practice, but we also wanted to learn from it and see what kind of challenges we would encounter. So what we did, we installed learning circles, in which we planned and reflected on what happened, and we could adjust and then again reflected on what was happening. And we did these learning circles on different emerging themes. So when we started, we knew some themes would pop up, but there were certainly different themes that at the beginning we would not have expected. And these were themes as the forms of governance that a board could choose, but also building trust among each other with other teams. And so also the theme of a community engagement, which I show you some examples. And as this is again my journey, this is one of my favorite pictures, which says like the change process. So everyone, there's always two things people would hate. It says change and the way things are. And that's sort of the difficult balance we also encountered. So we wanted to change, but it's also difficult for people to actually change. So some examples of what we did on community engagement. When we first started 2.5 years ago, the region already said, and in the plans it was there as well, we want to do something with community engagement, but we're not sure how to do it. So please help us how to do community engagement. So that was, again, the question from the managerial board member level of the region and the organization involved. So what we did, we provided the health kick team with knowledge about that, with examples from all over the world, how you could engage, which kind of people you would want to engage, different levels of community engagement. And then what we saw also in the reflection with the team, there was also the question of how to let the region do the community engagement. So not necessarily as the health kick team who wanted to support the regions, engage the people in there, but advise the region on how to engage their community. And as that, we also saw an extra layer beneath that for Health Kick. What, as an organization, then do we need to support the region? Are those more consultancy, advisory roles, or do we need to give examples in the region and really help them in practice to engage the right people? So that was really interesting to see that only providing knowledge was not necessarily enough for the region to take up, to do the community engagement. So, and there comes like a red cross. It seems kind of harsh because community engagement was really difficult. So in 2.5 years, there are no, for instance, community members now in the board. So it first looks a bit if it failed, but it's not necessarily failed because there are a lot of community up projects in the region, but they are not necessarily yet connected to the overall board and to the overall governance of the region. So that form of connection is really difficult as of now. So this is the examples of community engagement. We have overall lessons learned, so I will tell you then and then connect them back again to the community engagement that we encountered. So one of the big struggles, I would say, for Health Kick as a supporting organization was their positioning. So as I said, they really would like the region to take accountability, but therefore they were not sure how to position themselves because they had the knowledge, they had a good vision on how to approach, what to do, but it was difficult to actually get the region to do it. So that was a balance and a search for them how to do that. As also the organizations in the region were still forming the governance. So they were also not sure yet how to actually structure themselves and also who should take the accountability for the success of the whole initiative. So that was a big question that they were looking for, how to position themselves, and that was also where the action research was helpful in that reflection and adjusting. Other things we encountered was that new collaborations and people working together was kind of difficult. So the question arose, are you really truly able to understand each other? And that's simple on language, speaking different language. We would call the managerial language often office language. So it's a different kind of language if you speak to doctors, for instance. But it's also on really listening. Do you listen to each other? And also, again, to the butterflies, are you interested in their perspective and not only your own story? So with that came also the perspective of time. Do you have the time to truly understand and connect to each other? And that also came back in the sense that everyone was so motivated to change that everything seems to need to be finished yesterday. But then, do you take the time to reflect and connect and then go forward? Or is the action in the now more important? And then everyone experienced for themselves a sort of phase of muddling through. So they had to, for themselves as a personal experience, go through it, grow and connect and adapt to the change. And there the question also arose, are you able to learn from each other, or do you need that first personal experience to change? And when we connect that to community engagement, the accountability question of who in the region or Health Gig, the supporting organization, should take the accountability. That question was needed to actually take action, to actually engage the community in the region. And that's still, when that still is a question, they all look to each other, look at each other, and no one actually takes action. And on the understanding, you need to think with the community and not about it, and also truly listen to them and not only engage them and then again still not listen and do your own thing. But that's easier said than done. And on structure and reflection, what we saw, if you take time to reflect, it's easier to keep working on the change process. It's easier to keep the shared objectives in mind and not fall back into old habits, not think first on your personal interest, but reflect with each other and keep the shared objective in mind to make steps forward. But as said, that was really difficult. So looking back, everyone was glad that we did the reflections. But in the journey, my story, it was sometimes difficult to get all the reflections, to go after the team members, please fill in your reflections. So during the process, everyone was more focused on the now, but that reflection sessions helped also to keep the shared objectives in mind and keep working as a team. And the personal experience, yes, change takes time. As we have heard, being open to learn is really important. So lastly, take-home messages, I would say it's all about the people, forming new connections, but also connecting to other perspectives. And the question overall is also, who takes the accountability for the success of the regional initiative? So I would finish off with a quote of myself. The struggle was real, and I would say the struggle was really real. It wasn't always easy, but the learning journey was definitely worth it, at least for me. Thank you so much.
Well done. Thank you for oh, right here. Apparently I'm short. All right, well, thank you so much for that informative presentation, and I appreciate that you invited us into the space to consider different perspectives, and I love the imagery that you used, and that change is hard, right? We know that we need to change, we're invited, we're inspired by it, but we also have to sit in that discomfort of the uncertainty that it brings, right? So also I just want to say thank you so much for those who are adding their questions to the chat. Please continue to do so. Michelle will be coming up afterwards in our panel to answer any questions that you have. But now I would like to invite Sascha Vermeylen and Hilda van den Hout from Thomas More UAS to join us. Thank you.
I'm not so short, so you probably see me almost the whole of me. Okay, perfect. It was a little uncomfortable. Okay, so first of all, welcome you all to being here in this very interesting session so far. I hope I can keep the bar as high as it is at this moment. Who am I? My name is Sascha Vermeil, as they already introduced me. Thank you for that. I am the panel manager of LiCalab, the Living and Care Lab that is part of the Thomas More University of Applied Sciences. And today I will talk to you about including citizens in health innovation, talk about the Living Lab approach, and I will do that by starting with a quote. And what better quote than a quote of a biologist that's talking about a zoo? And look outside, we are in front of the zoo, so it's well chosen, so to say. First of all, it's from a biologist, a Dutch biologist, De Waal. When a zoo wants to build a new enclosure, they take into account which species it is intended for. Why should we, when developing society, pretend that we know nothing about the characteristics of our species? And that is exactly what we do in Living Labs. We get to know the characteristics of our species by including them in research about innovation. First of all, I talked about a Living Lab a couple of times so far, and I'm already 1 minute in my presentation, but what is a Living Lab? Now, this is a definition of ENOL, the European Network of Living Labs, and they define Living Labs as such. Living Labs are open innovation ecosystems in real-life environments using iterative feedback processes through our life cycle approach of an innovation to create sustainable impact. It's a mouthful, so to say, so let's keep it short into 5 key findings. The 5 key elements of a Living Lab are the following. First of all, it's about the real-life setting. We do not perform clinical research. We involve end users in their real-life circumstances. That's the first key element of a Living Lab. The second one is active user involvement, which means that we invite our citizens, our patients, our care professional into the design process of health technology. Second, the third one already, the multi-stakeholder participation. That means that we don't focus on one stakeholder in the process, but we think about the quadruple helix, which is already mentioned before by my colleague. So it's very important to include not one side, not one view, as the last image of the elephant was saying. It's better to include the whole picture, so to involve the different stakeholders. But also the multi-method approach is thereby very interesting to keep the methods that we use scientific. So it's qualitative research, not quantitative research, but we need to keep the scientific input high as well, and that could be very interesting in the Living Lab approach as well. The fifth that needs to be mentioned before I go on with my presentation is the co-creation session. Co-creation is the key word when we are talking about Living Labs. Co-creation is about creating together, don't do it alone, involve your stakeholders. So those are the 5 key elements I would take you through in the next few slides. So as I mentioned, we are not doing clinical research. We are not an effective lab that you can visit. We are a lab in our name, but not a physical lab. We include citizens, patients, care professionals into daily research by including them into their own live and working circumstances. That means that if we are developing a specific insole for Parkinson patients, for example, then we go to their homes. We go to the real living circumstances that they are in. Or for the care professionals, we go to the neurologists, for example, also to include them into our research. So not in a clinical way, so not in an effectiveness way, but in a way that we want to talk about usability, for example. But of course, the end user. I talked about it a couple of times so far, but who is the end user? Because it's a very specific, it can be a very specific profile. First of all, everybody is an end user. At this moment, we are end user of our chair, for example. We are end user of this ISIC conference. We are end user of this building. So we all can give feedback on the conference, on the hall, on the chairs we're sitting on. Of course, that's a bit too easy to say because it's about research in care innovation. So, for example, I take back my person with Parkinson's disease. If we are developing a specific insole for people with Parkinson's disease to make sure that they don't get freezing of gait, then we include the Parkinson's patients, but also the informal caregiver, for example, and also the neurologist, and also the physiotherapist, also the occupational therapist. So there are a lot of stakeholders that could be very interesting to involve in that research to make sure that it is the product where there's a specific need for in the field. That's why we call it the spectrum of end users. It's not only about the patients, it's also about the citizens, it's also about the care professionals, it's about whoever that could be interested in that care innovation. What we do is we detect needs and drivers. So it's very important to keep in mind that we do usability research. We make things better. We start from a specific need, and we want people to hand us the needs that they have. That we don't start from the innovation that says, this is your need. No, we start the way around. This is the need, and we want for this need a specific solution. So, more about LiCalab, because I already talked about living labs. LiCalab is a kind of living lab with a specialty in health services. So, living lab in care and well-being. You have different kinds of living labs. For example, you have a living lab in smart cities that is thinking about ways of making cities smart, for example, traffic-wise. You have also living labs when talking about agriculture, for example. We specialize in healthcare. So the only things that we do is provide services. We do research in the healthcare domain. We are a research group. That means that we don't invent innovations in healthcare. We do research about healthcare innovations. And we do that as part of the Thomas More University of Applied Sciences, as I already said. And we are located in the Kempen. That's in the north of Belgium, more or less 50 kilometers away from Antwerp, where we are now. We talk about innovation in a broad definition. What does that mean? It can be, on the first hand, very high technological, like the specific insoles for the persons with Parkinson's disease that measures the pressure when people walk to let them know when they freeze to the ground. And that's what happens with people with Parkinson's disease, or could happen at least. But it can be also very low technological. For example, there can be a walking rack or a walking aid that we have a specific clicking method so people can get up earlier. It can also be services, applications, so it's about innovation in a broad sense. We do end-user research, so we involve the end-user in our research through different methodologies. For example, the co-creation session, but also live testing, giving people different aids to test at home, use them, give feedback on a scientifically based, in a scientific basis, of course, and give it back to companies, organizations, local governments to make sure that these innovations can be adapted to the needs of those people who test the things. We are a panel-based living lab, and that's something that makes us, for LiCalab, a little bit unique in the sector of living labs. We have a huge panel at our disposal, and I will get into that later on. We also are involved in a lot of international projects, national and international. For example, the Interreg projects, I think probably a couple of you know, but also projects that are more nationally subsidized. So a lot of different ways of working together. A thing that deserves a bit more attention is our panel, the LiCalab panel. I'm a panel manager, so my specific function is also oriented about this panel. But what is the panel? We have a panel of end users. And first of all, that is a database, so to say, of 1,500 end users, more or less. End users could be care professionals, but also citizens, where we reach out to for different purposes. We personally invite them to join our research activities. So when we have a project about those insoles of the Parkinson's disease, we invite people with Parkinson of our panel. We have a couple of people with Parkinson's disease in our panel. We send them an invite, but also informal caregivers, etc. Of course, do we have all people with Parkinson's disease in our panel? Of course not, and we are aware of that. So we work together with a lot of intermediary organizations as well in order to reach out to the right target group. What we do is we involve those end users on a voluntary basis, which means that we don't pay them to be in the research, that we ask them to participate. And the way that they say it is interesting to participate is first of all out of interest. If you have Parkinson's disease, then it could be very useful to join research to get to know the different innovations that are in the field of Parkinson's disease being developed, but also a social activity. You meet people with the same disease, for example, but also people that are of the neighborhoods. So it could be a social activity as well. We provide coffee and cookies and make it cozy. It's not always that formal, of course. And that's also something that they really appreciate. And of course, if we are talking about the people that are retired and have more or less, so to say, a little bit more time, they say that they really like to join co-creation sessions and our research to make them feel useful. As well as people that are on working age but have a specific disease so they can't work anymore, they also say, Finally, a thing that I can add to society, or a thing that I can, where I'm specialized in and people see that I still can, so that those are the specific drivers of our panel to be involved. Something else that is useful for our panel to know, but also useful for our partners, is that we are an independent partner in different projects. That means that we don't develop health innovations ourselves, and that gives us not a direct link with the company or the organization or the local government. People are free to talk about their feedback, they are free to give their feedback, their honest feedback, and that helps if you're not from the company yourself, not from a local government yourself. Because people tend to be nice, and that's good, people are nice people, but it sometimes helps a lot if they can give their honest advice. And that is something that is quite useful if you're an independent partner. We say to the people, you don't hurt our feelings when you're honest. And that's something to keep in mind. Also, I talked about the database of 1,500 people. At this moment, we have 3 full-time equivalent panel managers in our team, which is quite, 3 out of 9, so to say. So we're not a very big team, but 3 out of 9 is 1 in 3, so is a panel manager. What we specifically do is we invite those people to our research, we let them join our research, but we also have to maintain the panel. So we have to make sure that we don't include the same people every week, for example, but also that we have to keep them motivated. We organize, for example, every 2 years a panel day where we invite them to, for example, go with us on a visit for Johnson & Johnson, or we organize some activities. Not to be competitive with other cultural organizations, of course, but just to give something back, because, as I already said, they join our research voluntarily. I know it's not that concrete, and sometimes explaining a living lab to people that don't know a living lab is a little bit abstract, so that's why I picked out 2 examples to go into more detail. First of all, the Moonbird. Moonbird is a Belgian startup that is invented as a handheld device to help people do respiratory exercises, breathing exercises, and it's designed for people with sleeping disorders. But it's very interesting to say that the tool started from specific questions from caregivers. So GPs and pharmacists took matters into own hand, and they said a lot of people are taking medication to sleep better, and that's some big problem in the region. So they addressed that, and they did a call in the way of an Interreg call, of course, so it was a subsidized project. But Moonbird reacted to the call, and at that point in time, they didn't have an innovation, they just had an idea. And that's when they came into this research, and they were thinking about a way how they can help people with sleeping disorders, but also people with a lot of fear, or people that are with a lot of stress, for example, to let the tool help them guiding those breathing exercises. To give you an example of how we as a Living Lab got involved into this project, first of all, when we started our journey, as I said already, the tool didn't exist yet. So we did a co-creation session. We invited people with sleeping problems around the table, and we discussed about needs. So the goal of this research was to find non-pharmacological solutions to sleeping problems or sleeping disorders. We brought those people together. We let them think about a specific tool. There was already more or less a first sketch of Moonbird. It was not working yet, but we brought those people together to think about that innovation. In the next phase, they made a prototype of it. So the Moonbird is a handheld device, and the belly goes up and down. It's like a small bird breathing into your hand. And the goal of this specific tool is that you as a person adapt your breathing to the breathing of Moonbird. So it's more or less guided breathing exercises through that device. In the next phase, we did a live test. So we invited 40 people to test Moonbird. At that point in time, it was still a prototype, The prototype was with an external battery, so it wasn't a fancy prototype as it looked now. It was with an external battery, and it was connected with a wire, so it was still very early in the process. But we already captured a lot of feedback about the size, the material, about how good the breathing rhythm, how good it's feelable, how good people can adapt their breathing. Also, there is an app. Do we need an app? What kinds of things do we need to adjust to make it better? So all those things with the basic prototype. Then in the next phase, we did another live test, also with 40 people, and that was the final prototype. So then the external battery was internal, and it was actually ready to go to the market product. So that was very interesting. Also, at this point in time, we are doing a research with the Moonbird itself for children. So we are involving children in co-creation sessions and live testing. But we also talked about physical performance with a soccer team, a professional soccer team, to know in what way breathing exercises can have an influence on athletes, for example. Another exercise, and I will stay short because I'm out of time already, is Bebop. And Bebop is a tool about preventive health. It's also invented by Vito, together with Thomas Medica. That's the largest organization of GPs in Flanders. And they stuck their hand together and they thought about a way to help people think about their preventive health. And they made a web application with a health guide with specific questions about your health and how you can improve your health. Based on those questions, you can get a specific advice, and that advice is linked to local activities. So when you get an advice, for example, that you need to move more, then you get all not all, but a lot of activities in your neighborhood that can help you to start moving more. So that's a specific example of how you can improve preventive health for people. So I hope this was a bit clear. We also provided a QR code if you have any more questions or if you want to get involved in another one-on-one session, for example. Please fill out your contacts via this QR code. We are also available after this talk, of course. I'll let it on air. So thank you very much for your attention, and I hope if you have any question, I'm pleased to answer. Thank you.
Thank you, Sasha, and I really appreciated your quote that opened it up. It provided some great context into your conversations about living labs. I'd like to invite the rest of our speakers up, and I'm going to turn it over to Michelle, who's going to lead the Q&A section.
Hello, everybody. I don't think we need the stand. What we'll do is we'll turn the mic so that anybody who wants to respond to a question can stand here so that they're hearable to our virtual audience. There is not a handheld microphone here yet. Thank you. So what I thought we could do is we would alternate questions from the room and questions from the online poll so that if people weren't familiar with the app, you can still ask your questions. We have lots of time for discussion, and I will manage the questions in the app. Thank you. Are you going to be Vanna? Thank you. Okay, let's start with a question. Let's go back to Eva, your presentation. There was a question about the engagement of people in lived experience in the intervention design, and you noted they were in the step 4, but do you have any thoughts about engagement of people with lived experience in earlier phases? You're nodding. Go ahead.
Very good question. It's actually something that we're very aware of, and now with the 3rd action plan we started doing that. Before we didn't, and we only involved them to ask them for feedback and to ask them for evaluation, but now actually we're actually changing that. For example, with the project we're working on, the guidelines for people with autism, we're now doing a qualitative study start at the start of the project, to interview them about their needs and about how they, what they need and what they need an intervention to look like. So this is an approach that we're only starting right now, but we're aware of that could make our interventions much stronger. And I really liked the presentation of the panel database, and I thought, oh, the ideal situation would maybe be if we had like a sort of panel of people with lived experience. I know they have it in other countries, and that would be maybe a bit of a dream that we would have to have such a panel of people with experiences of suicidal thoughts or behaviors, so we can actually involve them in our studies and in our interventions from the start. So very good suggestion. We're working on it.
Thank you. I think there's a follow-up question, though, in relation to, and this is actually, I would be interested in all of the panel's response to this. The idea of co-designing and building around person engagement, citizen engagement around sensitive topics. So Eva, in particular, thinking around engaging people around sensitive topics or topics that have a lot of stigma attached to them. And I'm wondering from each of your discussions if you might touch on that relating to stigma and co-design or in citizen engagement. Yes, thank you.
What we always do is invite people into homogeneous groups. So that is the first step into including those citizens, create a safe space, a trustworthy space, space where they can be themselves, but also meet other people with the same problem, so they know that they are not alone. That's the first step, I guess. So not include people with different illnesses, for example, but keep them separated, at least in the first phase. We once did a research about people with urinary loss, and we had also the fear of how do you ask people, and it's a sensitive way. But if you ask the question and you ask it nicely and you have a trust relationship already, or you can go through intermediary organization, people are still looking for a solution for their specific problem. So if you phrase it right and you can build a little trust, then I think some people at least will feel sure enough to be included in research as well. So I think those are two practical tips to include those people.
Thank you. Megan.
I can build off of that. So I think going off of the trust, it's not just about trusting the organization, but also trusting the people who are facilitating the conversation. Having that relationship between the patients and the facilitator is important, and that can be difficult when we're having focus groups with a large group of individuals and one or two facilitators, right? We're not having patients always engaging with the same facilitators, but it's also about knowledge and transparency and them knowing exactly what is going on. I think I read about how in one organization, a facilitator was changed in some of these planning meetings, and that led to like mistrust with the organization, and the individual just didn't want to participate in the planning with this during the study because they didn't trust the individual that was facilitating it, and they also didn't trust that the organization wasn't transparent about this change, about who they were talking to.
Yeah, and I would like to add on that from the perspective of the region, it's really nice that you have the managers of the panel that not, for instance, in a Dutch region, there is a deprived neighborhood that researchers are really enthusiastic about to ask the people for their experiences. But then again, if 100 researchers come in, the people there are tired of telling their story. And especially if they don't see that something is done about it, they will stop telling their story. So I think that's really beautiful of your panel, and it also shows that it takes time to actually manage the panels and make sure that if you ask the people for their experience, also connect it back to the actions that is connected to it, and actually show them that you're listening. So that would be really nice also to, in the region, connect that to the regional objectives back again. And there's, I think, the challenge to connect all layers in your region. And it shows that there are beautiful practices running. So we're going there step by step, I would say.
Thank you. Eva, do you have any other thoughts related to stigma?
I was just thinking about our target group, then people with suicidal thoughts. For us, it's very important to ensure safety. So I think for us, we would have think through also all the ethical consideration that we should make. But yeah, it's worth
Thank you.
thinking about it.
I'm going to pause because I think there may be a question from the audience. Thank you.
Hi, my name is, I hear myself in double. My name is Dorine van Staaldij and I'm a researcher from the Netherlands. Well, my research is on change management, so I found it really interesting to hear all the topics. And I think my question is maybe for Megan and Eva both. Because I was running, you were talking about evaluating your interventions. And I think that's already a good step because, well, in previous research, I think Megan touched upon that there's not a lot of research on the impact of such interventions. And I was wondering, to what extent do you, if you evaluate these interventions, also look at the process of implementing such interventions? So which steps are taken and which strategies are used to, well, sort of roll out these interventions? And not only looking at the outcomes in the end, but also looking at the process it needs. So I would like to hear your thoughts on that.
Yeah, it's a good point. Mainly we look at the outcomes, like how many people we reached with this intervention, what did people think of this intervention, did it has the effect of, for example, decrease in suicidality. But we also look at the process, but then more in general, like at the end of every action plan, we do a very thorough analysis of like the past years that the action plan was running, and we go to all the stakeholders which were involved in the action plan, and we ask them for feedback and how they look back on this topic. So it is something that we look at as well, but to a lesser extent than to the actual outcomes.
Yeah, so I think evaluation is hard when it comes to goals. Goals can change. It's hard to measure whether goals are reached. And especially if you have set accountability measures, if goals are changed throughout, that's hard. So I think focusing on processes and implementation is an important part of evaluating services. So specific to the person-centered plans at PHSS. So they do the annual goal-setting meetings, but they also have 6-month reviews of the goals. So how has the goal progressed? Where are we at? If the goal was changed, why was it changed? Did something go wrong? Looking at that, I think that is an important part to start, where accountability measures just kind of need to be put into the services, because that's how we follow through with evaluation of the implementation.
Thank you for that very interesting question, and it dovetails to one that was in the poll. So Wilma, I'm going to ask a question and then I'm going to tag on, because I think there was a question about building from evidence and what we consider evidence. So the question was, why should the interventions be evidence-based, and if it's evidence, does it disregard the knowledge of community? I'm going to add on a second piece of that, and I'd be interested in your thoughts. So evidence-based practice, citizen knowledge, and measuring what matters. So there's 3 pieces, right? There's who generates the evidence, how do we determine what matters, and then how do we conduct work that actually balances those 2 things. So I'm wondering, maybe you want to just go down the line and think about that, and you don't have to answer all of it, but there's some tensions there, I think. So just some thoughts.
Yeah, I think with kind of just like measuring what matters, it goes back to measuring what matters to the person. For goals, if we're doing the annual meetings, what has happened, if you have been at PHSS, we go back to their goals from the last year, what has been set, and measuring if that happened. And that was what mattered to the person a year ago, and it might not matter anymore. But going back and seeing that, did this happen? Did what you want, what you considered a meaningful life, did that happen within the year, or have you progressed towards it?
Maybe it's useful to talk about the iterative process then, because that's also very useful when we talk about quantitative research, or qualitative research at least. It doesn't mean that if you do co-creation or involve people in focus groups at this point in time that you do need to know the truth at this point. It can be an iterative process where you can ask people about your opinion at this point and let it, keep it rest for 2-3 months and then do it over. So I don't think you have to look at it as a part of the process that needs to be done now, but something that can be adapted during your research. I think that's also important to keep in mind.
Yeah, I think it's a difficult balance. So especially connecting it to the regional perspective, there's also a lot of political influence and political opinions involved. And I can explain that from the regional perspective, there's only so much money we could spend on health and care in the region. So definitely it's really important to listen to what matters and what matters to you, what matters to the community. But then again, in the end, you want it to be connected to the regional initiative. So we would use the process of population health management and look back into the data of the population. So use that as a start and see where what we would call the burning platforms are. And then look into what kind of population it is, what kind of group that entails, and then ask them also to share their story, and in co-creation with them, connect that to the evidence that there already is on interventions that could suit that group, but then make sure to really adapt that to what the people would need.
So in your embedded work in a region, did you have to reconcile those tensions between the desires and needs of a community and the population health management approach and what the systems prioritized?
Yeah, definitely. Yeah, definitely. And that's really difficult. So we were much more on a higher level with the board members still. Getting all the data in a first step of the region is already a challenge, and getting a good view on that. So we're now working with these smaller business cases, as we call them, to also show the people on the board level what the evidence is and how this actually could work. And sometimes for them you need to come with the hard data and not only with the community story. So you need to combine them both to actually let the story land with them as well. And I think that goes back to those different perspectives of all the people in the system. People need a different story to connect to their perspective to change. And that is a big challenge.
Thank you. Eva, considering you started with an evidence synthesis for your intervention, I wonder if you want to loop back to this idea of the tension between best available evidence and citizen expectations and needs.
Yeah, tricky question. I think we also need more than evidence alone. And often when we start a project or an initiative, we're going to look internationally, what is evidence, what studies can we find? But obviously, you cannot just say, oh, we found a study of an intervention that was successful in Norway, let's just implement it here and we're done. No, absolutely not. That's not how we work. Even with interventions that have been developed and tested in the Netherlands, we say, oh, wait, this seems interesting, but we're very similar, but still there are a little bit of cultural differences now and then. So we want to adapt it to our population, and we're always going to test it out with the population here in Flanders. So it's not just taking something that has been tested in another context and implement. It's really adapting it to the needs and the culture of the region. So it's not just looking at that evidence that exists already, but also making the evidence yourself or building new evidence with the population that you're targeting to make sure and to ensure that it's tailored to their needs. So. Yeah. Yeah,
I like your comment around what constitutes evidence. Yeah, in what context. Let's get the microphone for you so that
Sorry, I would like to ask a few things about, or whether you could elaborate on a few things on the Living Science Lab. Two things. I'm particularly interested also in your panel list. We have something similar in the hospital that we're affiliated to, where we have a list of patients that we can that have expressed interest in being part of research projects that we can then match to projects that are about to start in the hospital. Do you have any issues with regards to GDPR when you list these people, because you've got a long list of people, which over 1,000? And how do you deal with that? And my second question was, if I understood correctly, you mentioned that 3 out of 9 of your staff are patients with lived experiences or citizens. And do they kind of get paid, or what kind of status do they have in your team?
Maybe I mispronounced that, so sorry for that. We are 3 panel managers, so it's my function in the group. So it's not that we have lived experiences in being a patient, for example, but we are 3 people that are managing the panel. And regarding GDPR, it's a very good question, because that's quite important, specifically in Europe with the GDPR. What we do is always let them sign informed consents before a research activity. That's something that needs to be done in every research, of course. What we also do, especially when we want to make publication afterwards, is we go through a social or an ethical committee. Sometimes if we work together with hospitals, of university hospitals, there can be a medical ethical approval that we need, especially when we talk about patients or we talk about specific profiles that we want to include. If we want to include people that are not that specific, but for example, when we talk about preventive health, then it should be okay to only use those informed consents, for example, for every research activity. We, of course, in the beginning of this year, we started with a new panel database, which means that we are now collecting a little bit more data about people that we are involving in our panel. And also before adding them to our panel again, we ask them to approve again that they want to be informed about our research. So that's also via informed consent. We, in the beginning of our panel, but then I didn't work for LiCalab yet, so I might not pronounce it right, but we had a specific agreement with the government that we could hold on to our data a little bit longer as well. And we also about the ethical agreements of involving persons or involving people in research was also a bit different. So we got our ethical justification for a bit longer than other research groups, but I can't go into details, sorry for that. Mm-hmm. Subjects, yeah, yeah. Yeah, indeed, yeah. They're recruited to join us in co-creation sessions or do live testings. Yeah, can be both. Can be subjects so that they can be testing things at home, but it can be partners as well in the case of we include them for more than once. Yeah.
Thank you. There's a question here.
Thanks for the presentations. What would be next level, as the conference title is a participatory approach? Your stories show we listen to the stories of patients, public involved. But what's next level if we want really to co-create our interventions with them? So it still seems it's not like I'm complaining about it, because it's what you're doing is already great. But what's next level if we are really trying to co-create our interventions, for instance, on suicide, those people who you can't reach, and if you could reach them and you could ask them, well, how could we prevent from even reaching the point of thinking about suicide, and what should we do? So, we're still, we're listening, and we are the ones as professionals, we are implementing the intervention, but how can we reach the next level next year?
Also tricky question, a lot of tricky questions today. I think, like right now we say, okay, at this stage we're gonna ask them for feedback or we're gonna include them, but actually, yeah, they should be included in the whole process, and actually they should be like included in our organization itself. We should have, like, there was a question, we should have staff members who are people with lived experience and who can help us with that. So I think it should be more integrated and not like, oh, this group that now and then we're gonna ask for advice or feedback. I think it should be more at the core of our organization, and that's a big working point. I think not only for us, for a lot of organizations, we are used to this this environment where the experts develop something for the target group, but yeah, it's really needed to shift that, I think. So that is one of the things I think that could help, that we really focus on getting it more integrated in our work. Yeah. But if someone else has very innovative ideas, I'm very open to it and very welcoming. Yeah. Because what we find is when we do we do studies or we do calls or we have a focus group, that there's always a lot of response. So people are very willing to share their stories, to share their needs, to help us developing tools. So yeah.
I think it's a great question that really signals at what point are we going to jump the gap from, and I think, Annefrans, you said we need to stop talking about communities and start talking with communities. And I thought that was really interesting from a regional perspective, because I think that's what you're trying to get at. At what point do we actually start really doing this authentically, meaningfully, and have it built into process? Yeah. So I don't know, from a regional perspective, since you said it was actually a barrier to, I'd be interested in if you have thoughts that might respond to that from a regional perspective.
Yeah, I think it's a lot also about perspectives and how you go into. So it's also sometimes could also be small things in the language. So you said let them help us make up a project or help them us, and I think it should be the other way around, and that's just getting used to that. And we're all now trained to be a professional and trained to help them, but we are thinking from our own perspective. So I think that could really help to be aware of that, and that's also why I said my journey is a learning journey, and I really benefited from the reflection once every while to reflect on that. So is it my journey, or where am I looking at? So it should be the journey of the community, and I think it's in the small things to start off, but yeah, we should engage it, and I would also say see yourself as part of the community where you live in. But that takes reflection to see at what perspective you are on the table. Are you there as a clinician maybe in the conversation, or are you there at that point as a patient in the conversation, or are you there as, for instance, a board member taking part of the conversation? That really changes your interest in that conversation. So yeah.
So building on that, I'm just going to go down the line now, because I think, so Sasha, considering the Living Lab in the panel, how often do questions come from the panel that drive projects, or what do you do with things that people propose or suggest? What do you do with those in your Living Lab?
Yeah, that's a very interesting question, because that's something when we looked in the mirror, that's something that we need to do more often. So we always start from a specific research question and we ask people to give feedback on a specific problem or a specific issue, but sometimes, or most of the time, they do have their own ideas as well. And that's the art of capturing that and communicating it back to the community, for example, as well. And that's something that we need to keep in mind when maintaining our panel as well. And it's something that we are actually thinking about at this point in time as well, to capture more ideas from bottom up instead of asking them about specific questions we have. So that's at this point still an angle for us. Yeah.
Thank you. So Megann, as an emerging scholar, as an early career scholar, you noted in your next future research that perhaps exploring the question from the perspective of people with lived experience would be the next step. So do you think that is the future then for both your program of work, and how might that change how you would have approached your work?
Yeah, so our project is, well, the project I talked about today is part of a larger project. So they are looking at, other people on our team are looking at the perspectives of the person supported as well as other organizations. But I do think it's headed towards that. I think that also we need to support organizations in evaluating their services, and we need to have questions come from the organizations and the people that have these services, because if we're researching and we're evaluating the services, then we're able to create an environment where the services respond to the needs. So I think it also comes from just supporting the organizations to evaluate their services and listening to the people they serve and the communities they serve.
Thank you. We could probably spend the rest of the afternoon together. Unfortunately, the only thing between you and lunch is this wrap-up. So we're going to say thank you to each of the speakers for sharing your experiences and showing us what you thought worked and what was maybe some challenges and limitations so that we could learn from those. So thank you for that. And I'm going to encourage you to continue the conversation in the app. So there's a discussion forum in the app. You can search for each other in the app. There were questions that weren't addressed yet, but perhaps you can find a way to do them at the coffee breaks or in the mornings before the sessions. So please use the app. It's a great tool. And thank you all for your time together, your questions, your insights that are on the app. Thank you to my co-chair, session co-chair, Sarah Precious, and please enjoy your lunch. Thank you.